A very warm welcome to RIK Classic 88.2. This is Saskia Unreserved once again, and my special guest today, the founder of the American Medical Center, Dr. Marinos Soteriou. We're going to be speaking about GESY, the new national health system, and something of vital importance to all of us because we're all actually making a contribution to this. So we're going to hear all the ramifications of GESY. Would you like to begin by outlining the philosophy?
Well, the GESY is supposed to be a scheme that's supposed to offer free access, actually access to care to everybody on the island. The word free is a relative term in the sense that everybody's going to contribute to it based on their income, percentage-wise, obviously, as you pointed out. If that's fair or not, that's a different story. That's another topic. But then again, by defining the terms and conditions, how the game is going to be played, basically the scheme is trying to offer a uniform healthcare coverage. Of course, this is the idea, and this is far from what's going to be implemented, according to my opinion. The GESY has a global budget. The budget is not supposed to be surpassed in any way. It's fixed. It's a certain amount of money every year, and that amount of money is going to be spent no matter what. But at the same time, it's not going to be decreased in any way for any other sort of spending. Of course, there could be a variation to that amount based on, if we have a crisis situation, financial crisis, or if everybody's income is less, then obviously that's going to affect clearly the income and the budget for the GESY as well.
Has that been factored in at all?
Well, I'm sure there were some exercises on paper of how to, face these things. But then again, that brings us to our first and most important point. This new healthcare scheme is being implemented based on a study performed by a known company called Mercer. It is very interesting, first of all, that this study was commissioned by the government of Cyprus, and clearly so far the parties involved in the implementation of this scheme have never seen the study. The study was never released to the public.
All right, to the public, all right, but to the doctors?
Neither to the doctors, not to the public. And this is a very interesting point, and this is a point that raises a lot of questions.
Yes.
As we know, every study is an exercise with calculations and assumptions, and clearly based on what assumptions you put down on paper, you get a variable result. We would like to know what this study includes, how this study was designed, and we'd like to see the best, the worst, and the average case scenario that comes with every study. The different factors that have been, taken into consideration to get this study done are very important to be studied by the different parties and express opinions. So far, this study is controlled by the GESY authorities, maybe, I guess, Ministry of Finance and other people involved, but it was never released to be scrutinized, criticized, tested, and, if needed, improved. And this raises a huge question.
Yes. GESY is being managed by the Health Insurance Organization only?
That is correct. And it's again a relative term in the sense that there is representation in the HIO, the Health Insurance Organization, as you called it, and there is representation there for unions, for politicians, for patients, for technocrats from the GESY, but there is no representation of the physicians, which is another interesting concept.
I mean, it just seems ludicrous because without you there isn't anything.
That is correct. You would expect in an organization that supposed to dictate the terms of employment or occupation or whatever you want to call it, because that's another controversial thing. Whoever is involved in these things should have some feedback on behalf of the physicians, and I think physicians should be on the board of this physician and should not be excluded.
Absolutely. Have you obviously raised your concerns to the Minister of Health?
Yeah, but these are things that were decided for whatever reason, and that was the final decision that the physicians should not be represented in this organization.
Is there any conflict of interest that could be a possible reason?
I could not see one, to be honest. I mean, if a physician is supposed to implement this scheme, he should be able to express an expert opinion during the decision-making process. And the decision-making process are the board meetings of this HIO. So it would be sad to see these decisions being decided, and then when the time comes to implement it, then the technocrats, which are going to be the doctors who are going to implement this thing, will voice a whole bunch of objections and suggestions for variations, and that could come in retrospect. That's very inefficient, I think.
I see also that everything boils down to unit prices. Where did this come from?
Because it's a global budget and it's supposed to be fixed, and obviously I see some logic to it in the sense that the population is aging all over the world. We know that the fastest growing group of people are the people over the age of 80. People usually need care. I mean, when you get older, you're not exactly healthy. You need
things
some
go
sort
wrong.
of care. Yeah. And if you really look at it, I mean, 90% of our healthcare expenditure for our entire life is basically spent in the last 6 months of our lives. So as the population is aging and the need for care is increasing, and at the same time there's new technologies that are very expensive that are coming on the market and everybody wants to have them. These two forces are really pushing the healthcare expenditure pretty high. The average healthcare expenditure in the European Union is 9%. Some countries are spending up to 12%. The US is spending 16% of their GDP. So, and we're trying to fund the HIO-GESY scheme with 6% of our GDP, which is, I think, a big problem because the system is underfunded.
All right. If we just go to underfunded, does that mean that we are going to, in some way, receive less care, the general public? It seems inevitable.
The people involved on behalf of HIO, Ministry of Health and so on, they claim that they calculated everything pretty accurately based on the study we've never seen, and they are pretty happy that there will be no shortage of cash and no shortage of quality, and everything will be fine. We question that because clearly we do firmly believe there is severe underfunding, and that inevitably will translate to lesser quality.
Is there anybody in the EU, any country, working with that kind of budget that's been implemented in Cyprus, or that will be?
I think it's the lowest in the EU.
We're lowest again in the EU, and not for the best things.
That is correct. And clearly, I'll go to the basic dictum that if you pay peanuts, you get monkeys. So we have to realize that we have to invest in healthcare. The same, we have to invest in education. We have to invest in our legal system. But at the same time, I don't want this discussion to evolve around money.
No,
it's not just about money.
No, it's about the quality of health care. And if you constantly pressure somebody to do something, and to say to a doctor, you've got to see, 80 patients a day instead of seeing 60 patients because they've got to reach quotas, or for whatever reason like that, it eventually does boil down to that. And I think that there's a perception also from the public that some of the doctors are just looking for more money. And I want to point out that this isn't really the case.
That is correct. And I'll just point out to a few simple examples. First of all, some of the reimbursements have been announced, and we know what the unit price is for an electrocardiogram. We know the unit price for a mammogram, the exam for the breast cancer prevention, and so on and so forth. We calculated through some simple calculations the number of cases we could possibly do and the reimbursements and the cost needed to buy, for example, a mammogram.
The machinery.
The machinery.
Yes.
Yes. And based on our calculations, we're going to need about 30 years to repay the investment we made.
Oh, and that's by the time, that's when we've already got new technology having come in, and
30
so.
years. I mean, technology is coming out every 3 to 5 years. So how can we invest in new technology if we're getting reimbursed below cost and we need 30 years to repay for the piece of equipment we're using? This is not possible.
I hate to think what would happen if you need a Da Vinci for robotic surgery.
Right, that's going to be the possibility to buy that or to buy any cutting-edge equipment or any therapies, as far as I'm concerned, is going to be limited. I wouldn't go necessarily to Da Vinci. I'll put it in simple terms. If I'm a patient and, God forbid, I have metastatic lung cancer, that means I have advanced disease of lung cancer. If I go on chemotherapy, I have about less than a year to live. Now, there is a new therapy coming out. It's called immunomodulation. If I take that medicine, there are cases where people live 8 years or even longer and they're still alive because that thing has been around for just a small number of years. That thing has a significant cost. Is the HIO and the GESY going to cover that? Is it not? How quickly are they going to adopt new technologies and new therapies? How quickly are they going to adjust the budget? How far can they adjust the budget? And so on and so forth. There's a lot of questions to be raised about these things, and clearly the answers are not there. The excuse is, well, let's start and then we'll see how things go.
Oh dear.
I'm not used to that principle. I would like to know how things work. I would like to calculate things, and I would like to know where I'm headed, because this uncertainty that I'm going to start and improve as we go, it may apply up to a certain point, but I don't think it's something that we should adopt on day one.
Let's go a little back. The person in the street is making a contribution to this. Somebody gets ill, they need to go to the hospital. How is all of this going to work?
Well, starting May 1 this coming year, obviously the access to the tertiary care and the in-hospital care is not going to be included in the scheme. So this is supposed to take place after 2020.
So if at the moment you can't go to hospital
and get covered
and be covered.
Correct.
So we're only paying just to see a doctor
for primary care and certain secondary care services. So simple.
Let's clarify what's primary and what's secondary care.
To go to the GP to get your regular checkups, to do some blood testing, to do some diagnostic testing, an X-ray, CT, or some other stuff.
Yes.
This is primary and secondary care. Immunizations, some preventive stuff, colonoscopies, gastroscopies, stuff like that. Tertiary care is if you need to have surgery and you go into the hospital, or anything that requires full hospitalization.
Right.
That is something that's called tertiary care, and that requires hospital admission.
So at the moment we can't cover, we're only going to be covering the first thing. So what happens to the patient? Who are they going to see? Do they have to go to a hospital?
No, as a starting point, the patients will go to their GP. They're all supposed to sign up with a specific GP, and the GP is the gatekeeper, so to say, to the system. He's going to evaluate the patient's symptoms, and based on his conclusion, he's going to decide whether he's going to refer a patient to a specialist. If the patient needs hospitalization, that coverage starts in 2020. So we have a transition period of about a year.
Who are these doctors that we're supposed to go to?
The GPs?
Yes.
Well, the GPs are the doctors who are going to decide to enroll into the system in that specific role as a GP, because as you know, a lot of doctors have dual specialties. You can be a pathology expert, and pathology in Cyprus has a different term as the universal term of pathology.
Yes.
A general practitioner plus a cardiologist or a pulmonologist or something. So most of the doctors, they have dual specialty of internal medicine and something else. So some of the doctors may choose to enroll in the system as experts, as a pulmonologist or a cardiologist, for example, or some of them may choose to be as GPs.
So everybody has to enroll?
That's the other situation here. All the patients have to enroll. The physicians, they have the choice whether to enroll or not. But the problem is, if everybody's entitled to care based on this scheme on the island of Cyprus, a physician will have a difficult time making a living if he's out of the system. Plus, there are other questions and issues: who's holding his medical record, the patient's medical records, and so on and so forth. So this is one of the points that the doctors are raising, that in reality the system is forcing the doctors to join, and a free professional, a doctor who wants to practice as a free professional will not have a fair chance to do so. And this is one of the things that are now being studied on behalf of the doctors, whether these things are non-constitutional, because every free professional in the European Union should be entitled to adopt his own
Yes.
employment terms, and he should be able to function in a competitive environment where he can make a reasonable living.
What about if somebody doesn't actually want to go to one of the doctors who's in the hospital? And does it have to be at the hospital, or is the public still able to go to their GP, whom they still have?
The public can go anywhere they want to. Basically, they have access to the GPs, and they also have access to the specialists directly. They have a small co-payment, and ballpark figure of 30 euros, 25 euros, I think. And that 25 euros can be paid if somebody chooses to bypass the GP. So you can go directly to a cardiologist, to a pulmonologist, to a orthopedic surgeon, and basically you can get the opinion from that person, from that doctor, by just paying a small amount of money.
Does that doctor actually see that money?
No, that money will be deducted from the doctor, actually, and if you wish, there will be some sort of a penalty for the experts and the specialists not to see the patients without the advice of the GP.
What do you mean that it's deducted?
That money does not go to the doctor. That money goes to the system.
How does the doctor get paid?
The doctor will get paid from the system.
And when does the doctor get paid? At the end of every day?
That's
Oh, we've made, 10 euros today. We've made 15 euros. I mean, if you're doing electrocardiograms, you're in a really bad situation, because you've got a higher expenditure than your patient is actually paying. I mean, €7.50, and you've got an awful lot of responsibility for that, and you pay 20 euros to have your nails done.
Right. Well, we don't know when the doctor's going to get paid. I assume it's going to be on some regular intervals if the system works well. But then again, that raises the question about the unit price, if we want to go back to that for a minute. The unit price originates from some calculations based on that infamous Mercer study, which again, I stress the fact that nobody has seen that yet, except the GESY people and the Ministry of Finance.
Sorry, when you actually asked as a body of private doctors and hospitals, because it actually does affect you, what was the response?
The response is that was that there is a summary of this study on the website of the Ministry of Health, but that's only the summary. We want the whole study to be able to study it in detail and make some conclusions.
All right. It just, I haven't seen that particular website, so I haven't been able to see.
There is a 60-page summary on that website, but by far not the study itself. Interestingly enough, even Mercer itself doesn't mention anything about the study on their website. I'm not saying that the study does not exist. I'm just saying that there's a lot of weird things that come to the surface that ring a bell.
Who is Mercer? Do we have any background on?
Mercer is a well-known consulting firm that was hired to perform to this study, and basically they were given a mandate by the Ministry of Health, and they were given some guidelines, if you wish, and this is what worries us.
And a lot of money?
Clearly that costed a lot of money, but there were others that did studies as well in the past. There is a study by McKinsey that's been shelved somewhere and nobody knows details about it. There was a study by Bill Shaw from Harvard back then in early 1990s that had certain assumptions and certain points that were raised back then. But all these studies have been shelved, and
has anybody asked where they are? Is it
We
public
asked.
money that's been used to have all these studies, the study of the study of the study?
That is a lot of public money that was spent in this situation, and clearly the study was never given to the public or to the healthcare experts. And this is a weird situation in the sense that this is not a classified study. We're not talking about national security situation or whatever. This is just a study that says that if I do A, B, C, I'm going to have X, Y, Z result, and this is how I made my calculations and predictions. We would like to see that. We haven't seen it.
Right. So the unit price, going back to that, is something that has been actually devised by this study. How does one know if there's any sort of variation of the unit price? Because that could be catastrophic from my simple understanding of it for a hospital, for example.
That is absolutely correct. Basically, we're arguing that there is a so-called variable unit price. The system says that we predicted that you need, let's say, 500 orthopedic procedures per year. So the unit price is defined, and they say the orthopedic procedure has a score of 2, which means that if you have a unit price of, let's say, 3,000 euros, a score of 2 gives you 6,000 euros for an orthopedic procedure. Now, if we predicted that we're going to have 500 orthopedic procedures per year, and all of a sudden there's 1,000 orthopedic procedures per year, then all of a sudden the unit price goes down to half. This is a problem. On the one hand, this is a system that was devised in order to avoid, to give an incentive to doctors to operate without proper indications and abuse the system. But on the other side, the doctors who are properly exercising their duties, they're being somehow penalized. Yeah, in the sense that if somebody is doing a lot of procedures unnecessarily, the doctor who's doing his job correctly is going to get paid less. And the disaster in the whole story is the fact that you will not know the unit price until you offer the services, you perform the procedures, and in retrospect, at the end of the month, the HIO will come back and say, okay, this month we exceeded the number of procedures that were calculated, and that's why I'm going to pay you less than the unit price.
But the doctors incurred those expenses
Correct.
for care.
Absolutely.
So he doesn't know what his salary is going to be at the end of the month.
Not just the salary. We don't know as hospitals if we're going to get reimbursed above cost or below cost. How can you perform if you...
what happens if something goes wrong in the middle of the operation and you need something extra, or I don't know, you're doing a simple break and you find a carcinoma on the bone? What's going to happen in these situations?
In these situations, I assume there'll be some extra reimbursement, but the point is that let's not go to the complicated stuff. Let's go to the simple stuff. You do an operation, and you know that this operation will give you an X amount of money. If that amount of money gets reduced for factors that you have nothing to do with, and the reimbursement is below your cost, that's a complete disaster. You cannot function, you cannot make a profit, you cannot make a living, you cannot pay your employees, you cannot buy new equipment, you cannot do anything. And we're not talking about just the unit price going down to half or 1/3. I'm talking even a small variation in the unit price, let's say a 10% variation in the unit price, could result in wiping off any possible profit you may have. How can you function if you don't have any profit? You don't have enough money to renew your equipment, you expand to offer better services, new services, and so on and so forth.
Another very alarming point that I see is that if you've got any shortfall, you're going to go bankrupt. The government hospital is going to have money pumped in when they go wrong, from my understanding, because they're going to be covered with financial assistance in case of any shortfall. Am I correct in saying that?
That is absolutely correct, and this is another sticky point that we raised on multiple occasions. Excuse me. It is unthinkable to subsidize the public hospitals and let the private hospitals struggle, especially if the unit prices are below cost as a consequence or action of the public hospitals, let's say. And I'll give you a simple example. The ministerial cabinet recently made a decision that the CYBC, where we are today, will not air private paying advertisements because this is a government-funded institution and they don't want to unfairly compete with the private TV stations and other broadcasting stations. How can then be logical and accept it that I'm going to have a government institution again competing with the private sector and I keep on subsidizing? That doesn't make any sense whatsoever. Plus, this deprives the public sector hospitals of any incentive to get better, get more efficient, and try to improve in many ways. So I think this is a major drawback, and I suspect that this is one of the things that are listed in the famous Mercer study, and that's why the study is not released, because I have the impression that the study sets the standards, and one of the prerequisites of the system to work is that all the hospitals will be competing freely against each other without any subsidies. So I think that's a serious issue, and that should be taken seriously into consideration.
The government hospital, with regard to purchase of equipment, for example, and of updated services, I was personally quite shocked because I walked into the public hospital. I could go anywhere I wanted. I went into a doctor's room because there was nothing there. I could have picked something up. There was no security, but nothing whatsoever. So I wandered around up and down various floors, in and out. Nobody said anything, and then I left.
Well, this is the situation nowadays. I hope that's going to be improved one of these days. And clearly, this has to do with management, it has to do with the culture, it has to do with the infrastructure, and a whole bunch of other things.
What about, and I don't even want to go to cybersecurity, patients' files, records, and all of these things. All of this actually also is extremely important. You've got a lot of confidential material, and it needs protection.
Clearly, that's another topic that has been barely touched in the recent discussions for the new healthcare scheme. We were told that there is firewalls and different security measures that are being taken to avoid these problems. Clearly, that's not just a problem for the healthcare scheme in Cyprus, that's a universal problem. But clearly, that has far-reaching implications. And I'll add one more aspect to this. What happens if I'm a patient who has seen several doctors in GESY, and all of a sudden I want to get the opinion of a doctor who's not part of the system? What happens to my record? Does the doctor from outside have access to the system and to my records or not? If yes, how? And so on and so forth. So there are a lot of issues that have not been fully addressed, or at least they haven't been announced yet. And I'll be very curious to see what's going to come out when we put those questions to the authorities.
Let's go to some more safety requirements. The safety says that you have to have one bed, please correct me if I'm wrong, every 12 square meters for health protection, for health reasons, so that germs don't go around in wards and whatever. Please do correct me if I'm wrong.
Okay, what this is I'm talking about the law that regulates the activities of the private hospitals. This private hospital law basically dictates certain standards according to which a group or clinic or hospital should practice. And these standards have to do with safety, have to do with comfort, have to do with many things. Now, this is a law that regulates the private hospitals. This law does not regulate the public hospitals. Public hospitals are regulated.
Why? Why?
Well, that's a good question. I don't know why, because up to this point, the hospitals are the property of the public, and they are exempted from everything, from the town planning, zoning regulations, and of course this specific law for hospitals. Excuse me. Now, the question is, if I'm the state and I decide that I want these minimum standards for people to practice medicine in the private sector, why do I lower my guard and allow lesser standards to be implemented in the public hospital? Shouldn't I be the first one to implement these things and then ask the private sector to implement as well? What you just described is the square footage needed for one bed in the intensive care unit. That means in every 12 square meters, I'm allowed to house one bed. This comes for a reason, and the first one is to have the patient a little more isolated, not to transfer any germs from one patient to the other, to avoid infections. Infections cost money, they cause problems, at the same time for the patient's comfort, the family's comfort, and so on and so forth. If you go to the public hospitals, you may accommodate 2 patients in 12 square meters. Where do the standards go? Why do I want to apply lesser standards in the public hospital? That doesn't make sense whatsoever.
All right. Another question is that it doesn't make sense. It doesn't make sense from all the bureaucracy, all right, that's surrounding it. But what about the doctors? When you all stood there and you did your Hippocratic oath, you didn't say, oh, I'm going to be a government doctor, I'm going to be a private doctor. You all became doctors.
Well,
didn't you? Am I?
That is correct. We all became doctors, and we all practice in Africa on different terms. We've practiced in Europe with different terms. We practice in the US with different terms and conditions. And clearly, you're supposed to do your utmost to offer care and make patients better and try to minimize collateral damage, let's say, suffering, pain, and unnecessary consequences. On the other hand, if you're in a public hospital system and the system dictates to you the employment terms and dictates to you the employment environment and the equipment and everything, what can you do? Can you go on strike every day? It's not practical.
No, but surely at this stage you should be...
If I may say also that this is our biggest fear nowadays, that we all become employees of the system, of the GESY, and the terms will be dictated by the GESY, and we're now pointing out that these terms and conditions are lacking, they are not sufficient, and they have a problem, and nobody's listening. Everybody's trying to transfer these things to, oh, the doctors want more money. This is This is not what it's all about. It's about quality, service, accessibility, and results. So it's not just if I'm going to make more money and take more money home.
And I think doctors shouldn't be threatened. It's almost as if it's coming across like a threat, and surely that's a sort of classic case of rule and divide. What is the situation as far as doctors remaining together? We have such strong unions who dictate everything else. Is it not possible on this situation for all the doctors to remain united, to offer the public something better?
So far, the doctors are united after the last resolution of the General Assembly of the Doctors, and we're trying to present our case and our worries and our arguments and our positions in a unified way. I hope this continues because it's to the benefit of the patients preeminently, and I think that will be the case. On the other hand, don't forget, we're facing a situation where we're going through a major transformation, if you wish, or I wouldn't call it a revolution, but it's a major reform here in Cyprus. And unfortunately, our feeling is that the preparation for this is insufficient, the funding for this is insufficient, and we're starting a situation that has not been thoroughly studied.
Has the Finance Ministry said anything with regard to your questions and your concern that there might not be sufficient funding?
The Finance Ministry, up to very recently, about a year plus, insisted in having another study that would basically study the implications of the new healthcare scheme on the economy and the viability of the scheme, because don't forget, this reform has far-reaching implications on the economy as well. For reasons that I could not fully understand, it was decided that the study will not be performed. So I think the Finance Ministry now is in a holding pattern and on a wait-and-see situation to see how things will look.
What does this mean for you as the American Medical Center?
As you may or may not know, we are a center that started with a little different vision and aspirations than the rest of the hospitals in Cyprus. We try to create a hub for healthcare for the region. The hospital is designed to accommodate medical tourism, is designed to be a little more upscale than others, and we're trying really hard to change the general perception that Cyprus cannot be a medical tourist destination. If we go now and introduce the new healthcare scheme, and all of a sudden our funding is in danger, obviously those aspirations and those plans are going to have to be shelved, and we're going to have to reroute and redirect our goals. And I hope and pray and wish that we will not be forced to lessen our quality, and I hope and pray and wish that we'll be able to afford to constantly increase the quality of the care, the sophistication of the care we offer, and have the results that we have now that compare favorably to any European or US leading hospitals. So this is not just about money. This is about many, many other things, and preeminently it's quality, quality, quality. And I think the way things are done now, the way things are designed now, quality will suffer.
Yes.
And I hope not.
Well, you mentioned medical tourism. Is there any possibility of being able to increase and to have more focus on that, or is that something that is not really viable?
I think it is very viable, and come to think about it, Cyprus is sitting in a strategically very important position. We're sitting in the middle of the Eastern Mediterranean. If you look at our neighbors, most of them, they don't talk to each other. But most of them, with exception of Turkey, are in best of terms with Cyprus. So we could be a catalyst in the region for relationships with these countries. And the simplest, noblest, and the best way to do that is start with medicine, education, and certain other things. There's a major transformation going through education now. There's a lot of private universities that attract a lot of students from the region, and it has been proven that Cyprus can become a hub in education, and it has become a hub in education already. And I think the same thing could apply in medicine. The only problem is that the American Heart Institute cannot do it on its own. Other clinics cannot do it on their own. And definitely we need the support of the local authorities in terms of promotion and marketing and other tools and certain incentives, if you wish. It's kind of like we have with the Cyprus Tourist Organization.
I was going to say, do you have their support?
So far, I have to admit that the support is very rudimentary. It's not much to talk about. We have to set strategic goals in that aspect. There has to be funds allocated for that, and there has to be organized efforts on behalf of everybody. And we've seen lately a number of patients come from the surrounding areas to receive care, at least in our institution. We've seen even patients from Israel coming to us for care, which is a complete paradox, if you wish, because that's a very well-known healthcare destination with very high standards of care. There are reasons why this is happening, waiting lists and other issues in the Israeli medical system, and this is exactly what we're afraid that's going to happen to Cyprus if we don't play the game right with the healthcare reform. Patients will start looking for care outside Cyprus.
This is another issue that I wanted to raise. What about all this incredible backlog that one constantly hears about of operations and procedures that people are waiting to be done?
Well, first of all, allow me to observe that we don't really know the magnitude of the backlog. The backlog is it's a list that is kept by some physician, the director of each specialty, and we don't know how many of those patients are still alive, how many people died in the meantime, how many have been serviced in the private sector, and so on and so forth. So these backlogs do exist, don't get me wrong, but the true magnitude of that is still unknown. So there is no official site where you can call and sign up and say, hey, I'm here and I've been waiting for a year to get my coronary angiography or get my MRI or my CT. It's all kind of vague, and I think that's part of the problem that we have nowadays. Keeping data and records and statistics, it's, I think, one of the major problems we had in designing the healthcare reform to begin with, because they tried to design a healthcare reform without having proper statistics. How can this happen? This is not possible.
In a couple of days ago, the minister actually rubbished the notion that private clinics would boycott GESY. This was on the 17th of November. And he said that some have even signed up. Is that true?
Look, I want to make a couple of things clear. Both us as physicians and both us with a different hat as private hospital owners, shareholders, or operators have no desire whatsoever to boycott GESY. At the same time, we don't want to pay the price for the lack of funding for GESY and the lack of structure and the lack of thoughts that were put into the system. I personally, and I'm 100% sure the rest of my colleagues fully understand the problems of the patients. The patients don't have access to care. They have problems with funding. I see this situation every day. People come to us to get an operation. They don't have the money, and they either die waiting or they end up being treated in the public sector against their wishes, and so on and so forth. I fully feel for these people. I fully understand the problem, and I fully understand that there has to be a resolution to this problem. Not this way.
No.
This is the wrong way. This has to change. This has to improve. And I understand the resistance to improve that, and I understand the efforts to stain the name and the reputation of the doctors and blame the doctors instead of concentrating to what the doctors have to say about things and take the important things into consideration and improve the system.
Where do you stand now as the American Heart Institute?
Whether we'll join GESY or not?
Yes.
Well, as I said, we would like to join. At this point in time, I think there is information missing, which is crucial in order to decide what's going to happen. And clearly, every hospital would like to have access to as many patients as possible. So yes, we do want to be part of the healthcare activities in Cyprus. We do want to take care of patients in Cyprus. We do want to be part of GESY, but at the same time, we have certain limitations that we have to meet, and we have to pay our loans, we have to pay our employees, we have to pay for all the investments that we made, and we have to make sure that these things are met before we join or before we decide whether we join or not.
As a physician, as a cardiothoracic surgeon, what are your thoughts? And as part of a group of doctors, what is your next move? We heard yesterday that doctors and the health organization agreed on Monday to intensive dialogue this week in order to resolve differences.
Well, there is an ongoing discussion. There was an agreement on behalf of three parties involved: the Ministry of Health, the Health Insurance Organization, and the Cyprus Medical Council. There will be no public announcements, and there will be no discussions in the air as far as the current points of discussion is concerned. And I think we all have to wait for a few more days until these negotiations and discussions are completed, and then we'll see what the result is and accordingly we'll react. I cannot predict what's going to happen, but I hope and pray that the authorities will get out of their comfort zone and we start looking around and realizing what the problems are, and start looking at things with an open mind, and hopefully they will offer true solutions and not just some sort of a temporizing thing that's not going to work.
Do you think that the public is sufficiently aware of all the ramifications of GESY and how it's going to actually operate? Has there been enough dissemination of information?
I'm afraid that we have here a very similar situation as the Brexit.
I was going to compare it.
That's exactly what's happening. A lot of people came up with a lot of announcements, announcing a lot of things that are not realistic and they are not even true. And I'm afraid that the public is not fully aware of what's going to happen if the current GESY, as currently recommended and proposed, is going to be implemented. What the real implications of these things, they haven't been really understood by the people.
Do you think that they actually need to be? In the case of Brexit, they shouldn't have actually, in my humble opinion, even been asked whether there should be an in or an out, because they didn't fully understand the implications any more than we fully understand the implications of running a hospital.
Well, that's how democracy works, and I'm not here to challenge that.
Yes.
Clearly, decision among experts is a completely discussion among experts is a completely different situation than a discussion among the public. And clearly, I do believe that the public has been misled to some extent, to have false or very high expectations when it comes to GESY. When the reality will settle in, though, it's going to be too late. We have to act now, and we have to improve things now.
Is there anything that you'd like to say towards the public of action that they might be able to take before it's too late?
The public has to start asking questions, the leaders of their communities and further up. What's going to happen if this thing doesn't work? Because I'm convinced it's not going to work.
Is there any possibility of it not being started at all?
Well, that's a political decision that I cannot preempt. I hope that there would be some second thoughts, and there will be some delay in the implementation of the system until it's improved. I'm afraid, though, there is a lot of exposure, a lot of public sentiment going around, and I'm not sure whether the authorities and the decision makers will step up to this and say, let's hold on for a second, let's step back, rethink this, renegotiate it, redesign it if you wish. I think that willingness is less likely at this point in time, and that's unfortunate.
Does GESY have any impact on people who are living in Cyprus but not Cypriot?
Well, I mean, everybody's supposed to be covered. There are even people who don't live in Cyprus and are employed by Cypriot-based companies. For example, the shipping companies, they have a lot of employees who are overseas who never gain anything from the sea ever, but they still contribute to it, which is another big question mark. What's going to happen? Are they going to still stay in Cyprus? Are they going to move elsewhere? So,
if they move elsewhere, that means that they're not going to have that funding that they think they're going to have.
Correct. The contribution will be less, and the question is, where will the supplementary funding come from?
A lot of questions. I'm still waiting for the Minister to accept my invitation to answer them.
Yeah, that would be very interesting to hear those answers, and very enlightening, I'm sure.
Dr. Marinos Soteriou, thank you so much for being on the program here with me today, and we look forward to hearing the next development, and hopefully some of very pertinent questions are going to be answered.
Thank you very much for inviting me, and I hope we didn't ruffle too many feathers.
That's what we're here to do.
Thank you.
A reminder, this is RIK Classic, 1:30. We continue the program with Enescu and the Romanian Fantasy Rhapsody.